So let me, does anyone want to take a break or ask questions while I pull up some different slides?
Does EMS coming into your facility directly, are they telling you their 12 leads, or are they giving you an interpretation of the field?
No, we decided early on not to try to transmit ECGs. We decided it's better to trust the EMS interpretation of the EKG, activate the system, look at the EKG when they get there. If we're off, we just stop the whole process, get the patient evaluated for whatever else is going on. There are problems with transmission that can add other barriers, you know, and delays. For you guys on your end to fool with transmission techniques, and for us on the other end to receive them, look at them properly, and people who are local, the travel time is so short, it just doesn't make a lot of sense. You pay a lot of money for this technology, and with minimal benefit. Now, there's some interesting articles that have come out with iPhones now, because the quality of the iPhone is so good, you could literally put your field EKG under a light, and you could snap your iPhone, and you could send that immediately. Faster than probably any transmission system. If a doctor, like on-call cardiologist, had his iPhone and he saw that image pop up, he could say right from home, yeah, that's a STEMI. So it may be that technology over time will change. It's easier to do that, but right now I think there's just too many barriers. Anybody need a break? Or?
So Dave, would you anticipate any barriers to that iPhone technology idea?
Down here, we just don't have very good.
That's what I thought.
But,
so you have that problem.
But we wouldn't probably be sending, we'd be sending it into our own hospital, and yeah, we just don't have, well, there is a tower going in, but people are maybe increasing our.
These things change so fast, you never know. You know, in a few years, it could be everybody's walking around with a smartphone and is working in the ER, and you guys might, there could be a number of diagnoses, I suppose.
Do you actually read a 12 lead on the screen of an iPhone?
Yeah.
It's that small?
It's that clear.
You can expand it so you
Yeah,
can look at any, you can look at a
just zoom in.
complex if you wanted to fit it.
So we can utilize that in technology energy.
Yeah, sir? What did you say?
Oh, I was just ripping Jacob for iPads, so we can transmit.
iPad would be even better, because obviously,
Yeah.
The doctor said,
I know, I imagine, I don't have a pocket big enough
does
for
that come
an
into
iPad.
the STEMI grants?
Yeah.
I think we're waiting for them to do that for us, so we can get one of those things.
But it's the one that's reading and that needs, not the one that's sending, when you use your iPhone.
That's right. That's right.
Food for thought.
There's all kinds of apps out there now that are targeting us, you know, EMS EKGs, and, you know, they've got whole, you know, they HIPAA compliant and on and on and on. I just haven't had a chance to do my homework to get it mine.
I haven't transmitted a 12 lead. It's probably been 4 or 5 years we had the next bells.
Yeah, the infrastructure just sort of fell apart.
I know on the east side of Providence, Portland, they had a transmission system, they were working with EMS on
And
that.
it's still not working well.
You know, it's just, you just create barriers, sometimes it's better to teach people how to interpret the EKG, so I get that segues right into
Yeah, it does.
this
I know
discussion.
the iPad 15s have Bluetooth on it, so you can
And
set it up through that, so you don't have to hook anything up other than activate Bluetooth device.
it's interesting, I just read something about the apps that actually the FDA is getting involved in reviewing way apps are used for medical interfaces. Some of the non-sanctioned apps might come under scrutiny. So some of the stuff I already mentioned, greatest improvements in door-to-balloon time come from the field EKG, and the corollary is that the missed EKG diagnosis is one of the most common causes of delayed treatment. I've already showed you these slides, just the trends over the several years and the reduced times. We know that this is old information, 2006, and this area is really growing, but this just showed the potential time delays from various things that could happen. So, you know, pre-hospital EKG, you can save 15 minutes. Activate the lab with the emergency room physicians, you can save time. So we've worked through all these things. We don't have a 24-hour on-site cardiologist, but the cardiologists in our team usually are clearly, they have rules. They have to respond within 10 minutes. They have to be there within 20 minutes from that phone call. Most of us live close enough we can get there in 5 to 10 minutes. So that's not usually an issue. We do now, Marla's behind this mainly, providing feedback to the ED and EMS people about the times. We found that feedback is really important to keep people kind of motivated, plugged in, and get involved. Difference between field EKG and non-field EKG presentations. When we look at cath lab in-house field EKG, this is old information. This is a couple years old now. So you bring everything down, and it's kind of still what applies. We've actually wiped out quite a bit of the difference between on-call and in-house cath lab. For the field EKG, and that's below the 0 line here, here's the positive EKG. That's what really makes these graphs down. We create one of these bar graphs for every single patient that comes in, and then we combine them to give some of this group information. So once again, old data, 2004 door-to-balloon times for 365 patients, and Providence 2010 was down here compared to that set of patients. But everybody's gotten better. I'm not trying to say we're super better than everybody in the country now, because these programs are going on everywhere, and everybody's getting better. We see the overread situations, 10-50% overreads expected, or STEMI MI could be missed. So some of these false readings, and let's go through EKG interpretation. So some of this stuff is really basic for you all who really know EKGs. I'm sorry to bore you with it. Some stuff is higher level and you may not care, but we'll go through some basics. So we look at a QRS complex. Here's the P wave. Here's the baseline here. This is a Q wave, so QRS, where that comes from. R wave's above the line. S is the secondary negative deflection. And so we look at this J point, and we look at that area to identify the ST elevation. In this cartoon, it overlaps the T wave. That's what we want to measure for ST elevation. We know that we have a 12-lead system that kind of helps position, helps give you an idea where the position of the heart attack is relative to the site or segment within the heart. So your precordial leads, V1, V2, V3, V4, wrap around the chest, and then your limb leads have these axes that help identify the relative anatomy. So for people who aren't familiar, the coronaries come off of the aorta, just above the heart level, and that's why a dissection of the aorta can impact the coronary ostia. So the right coronary artery comes off the right side of the aorta and kind of anterior and right. This is a 90% situation. In 90% of patients, the right coronary is dominant vessel. 10% the left is dominant, which means it provides the posterior descending branch to the bottom of the heart. So the left main artery here, circumflex wraps around the back of the heart, posterolateral area is what we think about, and then the left anterior descending artery here in the front. When I show the angiograms here, you'll kind of keep in mind some of these things. So what is the diagnosis of a STEMI? So we look at 1 millimeter ST elevation in 2 contiguous leads, limb leads. When you get into the precordial leads, so the leads across the front, especially the right precordial leads, 1 millimeter is not specific enough, and so you'll end up with more false positives. So we'll often look at the 2 millimeter cutoff for ST elevation in the right precordial leads. If you have an old EKG to compare with, and you usually won't until you get to the ER, but that's very helpful. We also know that ST elevation changes in the EKG occur with time. So you never know. Some people don't call until they're at this level here. So you start to see these early changes here, ST elevation, and right now the Q waves haven't deepened. There may be no Q wave here at all, most likely. And then with time, you see the Q waves getting deeper, and the STs may actually come back down. T waves become inverted. In some patients who have left ventricular aneurysms, had a heart attack, say 5 years ago, with thinning and scarring of the heart, they may have persistent ST elevation. So you may have a pattern like this that can fool you. False positives, here, the big ones here, I'll go through each of these. Early repolarization, more common in younger people. Acute pericarditis, left bundle branch block, left ventricular hypertrophy with what we call altered repolarization. Electrolyte abnormalities like hyperkalemia can also fool you. There are conduction disturbances such as Wolff-Parkinson-White, where there's abnormal connections between the atrium and the ventricle that kind of send the direction of the impulse away from the typical atrioventricular node and can create disturbances in the EKG. And as I mentioned, old infarct with aneurysm. So in early repolarization, here we see a nice, crisp, clean QRS complex. This is a usually younger patient. Normal QT interval. QT interval tends to lengthen with ischemia. So when you see a little bit ST elevation, you see here, and there are other more obvious cases. This is a little bit subtle, but in the inferior lateral leads, you see the ST elevation. There really is not significant reciprocal changes in the opposite leads here. That would be characteristic of early repol. So think about it with your younger patients. With acute pericarditis, a couple of pearls to think about. So here you see diffuse ST elevation. So 1 and L would be the lateral leads, or 1 and V4 through V6 lateral leads. You have the right precordial leads, or the septal anterior leads. And you have 2, 3, and F, which are the inferior leads. And here you see ST elevation almost everywhere with no reciprocal change. By reciprocal change, I mean ST depression in the kind of the opposite area of the heart. If you had if you could look on the other side, what would it show? And usually in pericarditis, you do not get lengthening the QT interval. So that's a sign of ischemia when you have it. And also, this little clue here is the PR segment. We talked about that baseline on the little cartoon I had. And here you can see clearly the PR segment is dropped from the baseline. The technical term is subepicardial atrial repolarization changes. But basically, that's a sign of acute pericarditis. So often it's a younger person, you have diffuse ST elevation, no ST depression, and the patient may have pleuritic chest pain rather than pressure chest pain. You kind of put the pieces together and you may avoid lytic therapy in a young person. Left bundle branch block. So this tends to be, it's very common, but we see a wide complex QRS, and you see these deep S waves in the precordium. You see notching usually in the high lateral leads here.